Okay, so hopefully everyone is listening to the language that you're familiar with. And I probably spoke a little bit too soon in English when some of you might want to hear the remarks in another language. So I'll just briefly repeat again that I am Rick Spletter, an international trainer from just outside of Dallas, Texas. Vita and I, best of our recollection, met at a conference in Cape Cod, Massachusetts in 2005. And I was very impressed with what she had to offer at that seminar and just some of the personal conversations that we shared. She and her husband are wonderful people, so enjoy them a lot. And just for a little background, Vita was teaching at a university in Germany for about 7 years, and psychosomatics was the primary focus of that university teaching. Focusing on trauma and resonance has been something that she has been focused on for quite some time, and also on the self-care for therapists. Vita has been in private therapy practice for 41 years. She's been in supervision with Ben Shapiro for 20 years, where there was quite an emphasis on the voice. And she was certified as a bioenergetic therapist in 1991 and became an international trainer in 2010. She began doing bioenergetic trainings in Russia. And if I recall correctly, she did that for a brief period of time. And she is currently doing trainings in Switzerland, Poland, Lithuania, and Germany. And I mentioned maybe before people change to the interpreter of their choice, that Vita made the statement when we spoke yesterday that bioenergetics rescued me. She has great appreciation for all that she learned from Bob Lewis and Ben Shapiro, that hopefully many of you know, because my personal experience is that those two individuals, along with many others, have just made a remarkable impression on the bioenergetic paradigm. And I'll just finally offer that Vita practices in Hamburg, Germany, Northwest Germany. And I can't think of more to say other than she is a delight. And I think that you'll experience that. Maybe you have already experienced that with Vita, and that's one of the reasons that you're here with us today. But for those of you who don't know Vita, I know you will finish the day with a tremendous respect and appreciation for who she is and what she has to offer the world in general and the bioenergetic world in specific. Vita, it's been an honor and a privilege to be here with you, just to introduce you. And I personally look forward to what you have to share, having seen your outline, and very impressed with what you have put together for all of these people today. So take it away, Vita.
So thank you, Rick. I hope I can hold on to your promises this evening. So let's start. And first of all, I will say I have to talk slowly because of translation. And it doesn't matter to me because I'm not a native speaker. So it helps me as well if I can slow down and use my German English. I start with some personal remarks on my best trainer for learning somatic resonance. This is my horse. So horse riding is something where I learn a lot about somatic resonance, and I like the fact that the horse doesn't talk and that horses don't have projections in that sense of projective identification or countertransference or transferential stuff. It's easy with horses. They are very direct and non-verbal. So today I will give you some talk. I prepared a paper. Of course, I will read because I'm not so fluent in English with all that stuff. What I decided on, instead of showing slides or pictures, I will have a break for you doing a little piece of exercise for the ventral vagus system after half an hour and again after 1 hour. So these are easy going exercises, but effective to open the visual contact again, or to open the eyes and the eye block. So I will do this in between with you so that you are not suffering all the time from talking. So now I start with my issue, with my theme. I want to present today some concepts and findings around the theme somatic resonance and therapists as resonance body, and why I think it's so important and precious for us bioenergetic analysts. Also, I will mention some open questions regarding the ways of implicit resonance during a therapeutic session, and hope to inspire you for discussing those questions later on with your colleagues. Questions that kept me busy since decades in regard to somatic resonance and to complex transferential issues. Those were, for instance, what are the implicit resonance paths in the encounter between two beings? And what can be said neurobiologically about the implicit pathways of resonance by mirror neurons or resonance nerve cells? And what cannot explained so far? What cannot be explained so far? And how does the therapeutic setting determine the path of resonance? How do I develop my ability to resonate? And how do I protect myself as a therapist? Those are the questions I'm going along with since years. So I will talk about neurobiological findings on the somatic effects of resonance. I will give a short summary of concepts like empathy and countertransference. I will talk about some professional risks for therapists, the subject of self-care, and I will let you know about my favorite interventions, bioenergetic interventions in training groups. To start with empathy. Empathy was initially defined on the cognitive level as an ability to participate in the feelings and thoughts of another person. But empathy has a physical basis. The emotional availability of the therapist depends directly on these somatic qualities, especially on the capacity for grounding, breathing, pulsation, and vibration. Alexander Lowen was paying attention to the somatic aspects of empathy. He once wrote, I quote, "People whose body is so rigid and paralyzed that it hardly pulses or just pulses a little lack empathy. If your body is alive, then you are sensitive for other people and their feelings, and we feel also more love and pleasure." This is a quote from Lowen from 1992. But Lowen did not write on empathy and transferential issues like countertransference. He was not explicitly investigated this. At the end of the 90s, inspired by attachment research and neurobiology, then there has been an increasing focus on the therapeutic relationship in the field of psychoanalysis and bioenergetic analysis. And these exciting empirical research results on the implicit ways of interaction were influencing bioenergetic concepts. And colleagues like Bob Lewis, Guy Tonella, myself, and others integrated findings in their concepts and clinical papers. And there was a kind of hype, since we thought enthusiastically that now, finally, bioenergetic analysis concepts and methodologies were validated by empirical research. We did not do empirical research within our field, within the bioenergetic field, but started to integrate the publications of the Boston Study Group of Change, so Daniel Stern and others, and Alan Shore, and Galese and Rizzolatti, those who found the mirror neurons. So the important findings in that field were, we can say, approximately 90% of our relational knowledge is implicit. That means it's not conscious and not expressed in language. That's a statement from Daniel Stern. Then the results of neurobiology show us that the contact between therapist and patient is a contact from the right hemisphere of the client to the right hemisphere of the therapist. That's Alan Shore. Further on, the transfer of emotional information is intensified in resonating contexts. And Guy Tonella told us that the psychotherapist uses his own somatosensory processes to perceive those of the patient. And Bob Lewis told us that empathy is a talk of the two limbic systems of therapist and patient. I myself was very happy that the discovery of mirroring neurons seems to confirm on the level of neurobiology a part of my clinical experience of somatic resonance. I was not questioning that time at the end of the 90s that one of my ways to work with resonance is without visual contact, not looking at people all the time. Also, I was not questioning that time that the comparison between macaque, this type of ape, which had been the ones who were investigated by Rizzolatti and Gallese, and the human being like me is maybe not appropriate in terms of conclusions we can draw from this research. So our therapist's body represents, apart from technique, both the medium and the agent for the therapeutic process. And this is based on resonance phenomena in the shared presence of therapist and patient. It's done by somatic rhythms, including the sound of the voice. And this body-to-body talk happens permanently in a session. But not only therapists are gifted with this kind of resonance, of course. Maybe we are more well educated, attuned to it, but every person has this resonance in daily life. We are all gifted with these basic patterns of body dialogue, since our primary motivation is to bond to other human and to be attached to other human beings. So this is the main thing. We try to bond and to attach to other living beings and to human beings. And you all know these phenomena that human beings are synchronizing their mimics, gestures, position of the body, voice in contact with others, and respond unconsciously to the other's nonverbal expressions. So we can conclude resonance or neuronal resonance builds the emotional component of empathy. There are other levels of empathy, like the cognitive. We can mentally put ourselves in another person's shoes, or the level of action. We can consciously imitate the person, mirror the person, or showing altruistic behavior. But the emotional component of empathy is the resonance, somatic resonance. And all these three levels of empathy, they are all involving different parts of our brain or brain systems. So countertransference was seen by Sigmund Freud and later as well by Reich and Lowen as not clearly enough analyzed and not enough worked through parts of the therapist's history, and that this would endanger the therapeutic process if not being analyzed and worked through or reflected. The concept of projective identification stresses more the client's acting out of unbearable unconscious negativity in the relationship to the therapist. So these were the old concepts, one could say. And then at the end of 1996, George Downing started to write about body and word, his book, and he spoke about an induced countertransference, That means that the therapist can use his or her body as a channel, a kind of channel, and refer by this to the feelings and body reactions of the patient, of the unconsciousness of the patient. And those induced countertransferential phenomena may reflect the feelings of the patient as a child, and this may be named concordant countertransference, or this induced countertransference may mirror to the therapist that this is the feeling of the parent of the patient, what the parent felt in the past. And this is named complementary countertransference. So these are the concepts we had so far until it started with the hype about somatic resonance. And it was very valuable what George Downing started speaking or talking about the induced countertransference, and to use the body of the therapist as a channel and getting a taste or smell of what is unconsciously going along in the patient, or going forward or not. So if we work with a patient who has lost the capacity to feel and to be conscious about his emotions, then we can use our body to feel instead of the person in front of us, and we can share. The breathing of the therapist is the central key for perceiving it. So in body psychotherapy, it doesn't seem, it is questionable, I would say, to make use of classical analytical concepts in terms of transferential issues, because they are not pure psychological processes. And the traditional concepts that were used in psychoanalysis, they were originally tied to the physically abstinent couch setting and a monadic position of the therapist. Instead of this, in bioenergetic analysis, we are directing our entire physical attention to the person opposite to us. So it was Alexander Lowen's merit to put the adult patient in motion at the center of attention in the therapy process. In contrast to the sitting position in verbal-oriented therapies, bioenergetic analysis is practiced in an open setting, and this could be we are either standing or sitting or lying down. Same for the therapist. I mean, the patient can sit or stand or move or lay down, or the therapist can move together with the patient. So we are listening, we are applying bioenergetic body interventions, and same time we try to move together to adapt to the patient's nonverbal expressions, mirroring or synchronizing. So therefore, the relationship in body psychotherapy in whole and in bioenergetic analysis is becomes much more complex than in therapeutic sessions where the position is fixed, like sitting face to face or lying on a couch with the analyst behind. We are taking different positions in the room with the patient and move more or less together, or the patient is moving. Other inner images are evoked, and transferential processes are different and more real. And corrective emotional experiences may happen. Regarding research, these active settings seem more complicated to describe, to investigate. And neurobiological research is far from that kind of complexity. We would need to explain the process of unconscious interaction during a therapy session with more complex means. So what are, again, more diving into this implicit way of resonance by neurobiology. In the meantime, the results are showing open the door for further astonishing insights for us if we want to look at implicit ways of resonance. In general, there's a consensus that every emotion is tied to arousal, and emotional exchange between two people can create an energetic field. In the best case, synchronization and synergy. And these resonance phenomena happen far below the normal reaction time. So it's a third of 100 seconds. So it's, I cannot spell it in English. So it's less than 1 second that it happens, that psychological signs of two persons are perceived mutual. And emotional patterns are reflected in facial expressions, gestures, vocal expression, sound, posture, movement patterns, and breathing patterns, maybe smell. And we can feel in a sudden, for instance, if we stand in an underground or metro and without turning around, we can smell, we can feel if a person is standing behind us and this person is maybe angry and tensed, or this person is charged with sexual arousal or anxiety, and we can feel without looking. So those implicit ways of resonance are same time happening in a therapeutic session without being all the time conscious or consciously perceived. So we see each other, of course, but the human eye is not a camera. Our sensory and brain systems are creative. They make hypotheses about what kind of faces, facial expressions, hand postures, gestures, and body movements are relevant. And our system is distinguishing biological from non-biological movement. For example, if we follow a football match or a dance performance, and if we are very identified with the actors, we as observers can measure similar activations for the innervation of the leg muscles in the premotor cortex. In face recognition, our eyes are making scans of movements, or scan movements, and we are scanning the movements of the other. And we first are scanning the eyes and the mouth, and then the hands. And this is a bottom-up process. When analyzing the movements of living organisms, cells in the temporal lobe respond more strongly to mouth and eye movements, as well as to arm and leg movements. In particular, we visually show somatic resonance to other people's eyes and facial expressions, hand and movement. Most of the time, language and body language work together to trigger resonance. When speech, when the talk and the body signals contradict each other, body language has a stronger effect than speech on being processed in our brain. Facial recognition seems to follow many principles of Gestalt psychology, what means that human brains prefer to follow or to see faces, especially in an upright position. So our brain clearly assigns a special position to faces that require an upright alignment of the face. So if I would do this or that, your brain would start to look how to get my mouth, my eyes back. Knowing this, we can argue against a therapy setting in which therapists constantly see their patients on their heads. I mean, why do classical psychoanalytic therapists sit behind the patient at the head end of the couch so that the perspective thus becomes an overhead perspective, so not really fitting with what our brain likes to perceive. Emotional expressions which indicate fear, anger, terror, or hate cause activity in the amygdala of the observer and are compared there with other dangers. So only seeing those faces activates our brain in that part where we are coping with dangers. The feeling of disgust or unwillingness triggered by smelling or inhaling something unpleasant activates the same neural structures as when we look at the face of a person who has a disgustful expression. So seeing a disgustful expression activates the same brain mechanisms than smelling something disgustful or feeling yourself like this. Same with embarrassment. If you see somebody, observe somebody who feels embarrassed, this activates similar or same areas of your brain as observing physical pain of another person. And embarrassment can itself cause the processing, the perceiving and processing of pain in the brain. So I will do one more and then have a little piece of exercise for you, because it's a lot of stuff to follow and you see me all the time. I don't see you. But let's go further on with emotional expression. And you know all, I guess, Stephen Porges and his polyvagal concept, and what he is saying about the neuronal control of facial and head muscles. Our facial and head muscles, with the help of the nerve pathways which connect the cortex and the brain stem, make our face expressive, and allow us to convey meanings through mimics. Same, they are influencing the sound of our voice, and they help us to focus our gaze on certain things and direct our hearing to distinguish human voices from background noise. It is the ventral vagus complex which is related to the expression and experience of emotions. And our heart is neuroanatomically connected to facial expression, voice, sound, and melody, which is an important precondition for a person's sense of security and emotional devotion to the social world, both in the metaphorical sense and according to the polyvagal theory. Now, following poetess, I would like that you do a little piece of exercise for unblocking the ocular segment or the eyes. It's easily done. I don't see you, but you see me. We start, because you are looking for a long time at the screen and sitting, we start by imagining that our hip bones are like flashlights of the car. So don't move your hips, don't move your upper body, beside turning around and see if there is somebody behind you, as far as you can turn to your left shoulder, and wait in that position until you feel a need for a deep inhalation. And only then, if you inhaled, then coming back slow motion to the middle position. Take a deep breath and wait a moment. And do the same to the other side. So look over your shoulder, not moving the upper body, beside the scalenus muscles, and turn your head around as far as you can and wait for deep inhalation. It's a reflex then. And then after this deep inhalation, come back to the middle position and sense how your body feels and how, especially how your perspective is, your visual contact, how you are seeing the screen or me or your friend, if there's somebody. Then we are doing the same without turning the head. So we move only the eyes and look aside as far as we can, not moving the upper body, not moving the head, only with the eyes to one side. And again, wait for deep inhalation until this reflex starts, and then come back to the middle position and sense your body and feel and sense the perspective of your eye, look, your sight, your vision. And do the same to the other side, only moving the eyes, not moving the head. The upper body stays. And wait for the need to inhale. And then come back to the middle position and sense your body and how it feels, how your breathing is. Your perspective may have become a bit wider, like 140 degree to both sides. So this is one thing to activate, to tonify the ventral vagus, to get out of a tunnel look or to get out of restricted perspective, as it may happen if one is staring at the screen or focused on a theme very attentively. So I continue now with another path of implicit resonance, and this is that we hear our patients. The sound is an energetic door opener, and the resonant voice reflects even more than the speaking voice, the sounding, something about our current mood, our internal state of being, and as well as maybe about some deeper levels of our being. The sound of the voice let us differentiate emotions from each other, and we have different tempo, articulation, and pitch, and we can stay attentive and listen to the other and let us be touched or be like an instrument being vibrating or pulsating by the other's voice or resonating to it. So we hear, unconsciously or not, we hear if the sound of a person is authentic in a verbal statement or not. Another path of implicit exchange and somatic resonance is the touch, the tactile contact, the touch, hands-on interventions, or holding or giving body resistance to a person. And we can say a touch with meaning, with inner pictures, and within a trustful or confident relationship, stimulates other reactions via vagus than just a mechanical touch of a stranger. If body interventions are applied purely mechanically without taking into account the relational statements in them, for instance, in massage or physiotherapy, if it's done technically, the psychotherapeutic effect or benefit is minimal. This applies both to affect regulation and to the comprehension of oneself or the contact with the other. So if there's a mechanical touch which is not combined with a trustful relationship and with some meaning and inner picture, it's mechanic, it's not resonating really. Then, as you know, maybe because some people may have read my paper in former times, we sense or feel our patients even without physical contact, even without eyesight, without looking at them, without or with closed eyes, we can take a lot of information. So in addition to visual perception, we have other sensory channels which are contributing to immediate unconscious process of somatic exchange. like rhythmic signals, heartbeat, breathing rhythm, sound of the voice, or the degree of tension in the muscles, the muscular tension patterns, the quality and the pattern of movements, or sensations like coldness and warmth, or heaviness, lightness, contraction, expansion. They also provide clues to know which person is there, who is there, what is more than being talked about, what I'm getting of this person. Even signals on a vegetative or hormonal level. So we know that breathing rhythms synchronize, as do postures and movements. And the more intense the attunement to the other person is. In particular, breathing patterns shed light on one's ability to use the body resonant spaces to hold to develop first, to develop emotions, to hold emotions, and to express emotions. So we need the amplitude of the breathing rhythm to be expressive and to be sensitive. It's a pulsation that we need, and we need this inner space to feel the other. And the therapist is using her own breathing rhythm and heartbeat maybe as an indicator to perceive the extent of what is maybe as aliveness in the patient, or excitement, or pulsation. And so it can be perceived on different sensoric channels, but mainly the breathing rhythm and maybe our heartbeat and the feeling of coldness and warmth are giving us information. And many of these sensoric experiences are having an echo in nerve cells of our brain. But as I said before, neurobiology is far from being able to grasp the enormous complexity in the process of unconscious interaction during a therapy session by delivering appropriate research designs. So I could not find any special note, while reading for this talk. I could not find a special note on neurobiological research designs on breathing patterns and patterns of body tension, which are especially important for bioenergetic work. And the whole hype in the discussion about mirror neurons is mainly about feelings, actions, intentions another person or being is having, and how this is causing the observer mirror neurons to fire. But how do we get information in our brain about the breathing pattern and the movement patterns, and beside touching the person or beside palpating muscles? We get it maybe over a distance of some meters. So I liked to read a German neurobiologist named Joachim Bauer, who was proposing to name all these nerve cells, which are the ones who are enabling us to have somatic resonance and processing this resonance in our brain, not only mirror neurons, as it was since the end of the 90s. He says we should name them resonant nerve cells, because they are including more than visual reactions on a human or a living being. So all nerve cells that reflect the neuronal activity of an observed person in an observer in a specific and selective way can be called resonant nerve cells. It's not only about mirroring, because this was more combined with visual contact and maybe observing people with eye look. So, but we are reacting on other sensoric levels, and we should broaden the concept of mirror neurons to resonant nerve cells. Now, I have time still about self-care for therapists. Regarding the self-care system of the therapist, we may consider that the immediate exchange and the involuntary resonance, somatic resonance, with so many unconscious feelings of our clients can be a risk for our mental and physical health. I'm sure that all colleagues are aware of the phenomenon in question. For instance, the headache of patients, their hunger, their feeling cold, their depression, their difficulty to be alive and joyful. And those sensations may settle down in our bodies during a session or after a session at the end. And sometimes it's a more complex picture or image that appears, but sometimes it's only a somatic reaction and some complaints we are having then after having seen a patient. And because of the intensity of this resonance, we are nevertheless at risk to develop secondary traumatization. If we do not dynamically initiate our ability to distance ourselves and be an agent in the therapeutic process, who is not only behaving as a container, taking in and enduring. Because social and physical systems of pain perceptions and this processing of physical and emotional pain are connected. So it doesn't matter if it's a social pain or a real pain, like a hurt of the tissue, but the processing is similar in our brain. So, and that means we share also the pain with people who are close to us and with whom we empathize. Insults and hurt feelings are experienced in the same way as a physical pain. That means for us, therapists, especially with narcissistic patients and borderline patients, we are in danger. We are in danger to be devaluated, to be excluded, to be overlooked. And Daniel Siegel was sometimes saying that those social hurts are causing the same pain like a knife who's passing your heart. You can measure the same signals in your brain. And also, emotional expressions which indicate fear, anger, hate, terror, cause activity in the amygdala of the observer. If we see somebody like this, we are having the same processes in our amygdala going on, And we are then comparing it there with other dangers we had experienced in the past. That means also, while having contact, steady contact with the average depressed patient or traumatized patient, we will get nonverbal signals which fit to all what Stephen Porges told us. So we look into a face where the ventral vagus is causing what, because it's not tonified. We see the eyelids drop. We hear that the voice, the vocal expression is not modulated. We don't see positive mimics or less often. And the sound of the voice is maybe more perceived indistinctively. And the sensitivity to the other person is reduced in social contact. So if we then start to protect ourselves from those impressions, having a person in front of us hour by hour, looking and talking like this, we may stop breathing. That's one way to protect and not to take in. But shallow breathing and lack of vibration in the therapist and reduced motility weakens the immune system. And deep breathing, vocal expression, laughter and singing is positively stimulating our immune system and even on the hormonal level. And shallow breathing results in a lack of oxygen and limits our vitality and emotion in such way that we produce little vibrant impulses and receive correspondingly little feedback. At the same time, the breathing pattern is the royal road to come out of this danger. Carl Gustav Jung, the Swiss analyst in former times, he said that the therapist must infect himself with the neurosis of the client, and by the attempts of the therapist to heal himself, the client will be healed. Thus, we could allow ourselves to be infected by the client, but maybe with less rigidity, with less endurance, with less containing and balancing between openness and keeping our boundaries. It sounds difficult. It is, I guess. So it's about how do I develop my ability to resonate and same time my self-care. It's all about breathing and grounding, of course. And in bioenergetic analysis, we understand resilience and vocal expressiveness as a physical concept, which is connected. So we need to train our capacity to deeply breathing and to have some vocal expression in order to care for our instrument, of course. Especially in order to build boundaries, we need something like blowing up and holding for a moment, and even holding the sound if we are producing a sound. So it's not about sighing and mourning and letting go all the time. So we try to erect our upper spine and to have some rigor or vigor, and to tone ourselves and hold, or to fill up ourselves with some more breath. And this changed muscle tonus may have some expression that the other can see. Okay, this person is now not going to take in. I shorten it here at that point because I want you to give some more time to tell you about my favorite exercises in training groups, and start with this now, with the practical part. You can read about resonance and about the voice and self-care in my papers. You can download them from my website. You can download the IIBA journal, and they are published. So I will go on with my practical stuff because I guess it's of interest for you to have some example how to practice with those with this focus on resonance, somatic resonance, how to apply it in bioenergetic sessions or in a bioenergetic group. So I use somatic resonance first. I use it for diagnostics without having look at the person. So I stand maybe 30 centimeters aside and behind, in front, and on both sides of a person with closed eyes. And I start to sense what kind of information on the level of sensation is coming from the other body. And then I share. So, and this is an unconscious process from the patient's side, of course. The patient is just standing there, and I say, okay, give me a chance to sense who is here. And then I reveal this kind of somatic resonance, and the patient can tell me how it resonates in him or her, and what it maybe connects with some issues, some themes, and some experiences from the past. So each part of the body is telling something. And though this is a build-up process, I start with sensations, then maybe revealing or sharing feelings, and sometimes inner pictures are coming up and I share them. So that's a part of diagnostics in the beginning of a therapy process, or one can do this in groups, that people close their eyes and they start to sense who is there and what does the body tell without talking. What I like most then in groups is to do body reading in motion. Body reading in motion is based on resonance, on repetition, imitation as principle. I will tell you. So I ask for the classical bioenergetic intervention, like kicking on the mattress, and don't give instructions in the first moment. So I ask the person to do it like he or she is doing it, or the body is doing it spontaneously. Then after a while, the group is asked to give resonance, somatic resonance first. So it's not about giving instructions or how it should be done better. It's not about evaluation or in any kind of directive exchange. It's the group is sharing somatic resonance to this pattern of moving the legs and kicking the mat. And so we are sharing this first, and the protagonist is hearing what the group is resonating on the somatosensoric level. And then next step could be to share emotions, then feelings, thoughts, or pictures. So I use the pyramid of the self as how to say, to teach the group to really base their perception first on the sensomotoric level, then affections or emotions, then feelings, which is more near to mental processes, and then thoughts and images. So not to disturb the process of the person who is kicking by evaluation. And then second trial, or maybe third trial, and this could be then quite another trip, because there was this choir, this whole resonance and synchronization of the group and sharing, and then the body moves differently in a second trial with kicking. And maybe somebody was saying, oh, I felt it was breathtaking. I couldn't breathe while you were doing this, or I felt like a racing mouse in the circus, or something like this. So this will then again inspire the protagonist to do a different kicking. Same with hitting the cube, first trial, and then resonance of the group, and then second or third one. And I call this body reading in motion because it's same time diagnostic and intervention. And there's another principle in it, which is so necessary in childhood, in developmental stages, different developmental stages. We learn by repetition. I mean, we learn by the body of the parent, we learn by resonance, but we learn by repetition and having time for repetition. So this is very important developmental principle. And I tell to the people that they don't have to strive for perfect performance or for doing the classical bioenergetic interventions or exercises in a right way. It's not about the right way. It's about what the body is telling, what the group as a new family is maybe resonating, or how the group is resonating and sharing. And then the body will find a way in a second trial, in a repetition. I use the principle of the how. I mean, Wilhelm Reich was the first one who was writing about the how. Same was in Gestalt therapy later, that the how a person is doing something, how the body is doing it, is so decisive, or so, how to say, it's so important to give information about unconscious and non-verbal stuff. It's not about the what, because this leads to clarification and thoughts. What, I mean, the content, and the what is more mentalizing, or leads to more mentalizing. And then the why, which is leading to the past, and maybe inspires to explore biographical stuff, but then maybe could lead back to the trauma, and maybe back to the victim position. So I guess that the focus on the how a person is doing this, how is the body doing it, may offer some more opportunities or open some windows for resource-oriented work or finding new ways. So if we include the how in our somatic perception and resonance, we choose the implicit path of resonance, I would say. Then another principle, the last principle of development, in childhood, we imitate everything the parents are doing, even unconscious stuff. And so imitation is a very important principle for learning. In Bioenergetic groups, I ask a person to walk around in her or his style of walking, his walk or her walking pattern. And the group is observing, resonating, I mean, looking how the person is walking, and then imitating. So one who has an idea, oh, I could walk like this person was walking, is imitating and doing the same, walking this way around. And then the protagonist could see, okay, this is the way I'm walking, how this person is seeing it or mirroring it, imitating. And if this is causing shame, I do it in small groups, not in a big group. But if you see maybe 3 or 4 persons walking or like you are walking, and that they are trying to imitate you and your walking pattern, you can get a smell of what is non-verbally, unconsciously put out by your way to approach the world, or maybe to keep people in distance. I remember one person saying, oh, I never knew before I saw the imitation of my walking pattern, that the social world can see, even by this, how aggressive, what an aggressive person I am, only by seeing how I am walking and how people are mirroring or imitating this. So this is, I would say, a very, impressive or precious way to do the classic, or to change the classic bioenergetic diagnosis or diagnostics into a more sometimes funny and pleasurable and some precious process on the basis of resonance, and on the basis of, or using developmental principles, how we develop by imitation, by repetition, by seeing the other, how he or she is doing it, and so. And this is, of course, more consciously done than the somatic resonance, which is based on nerve cells, neuronal nerve cells. I will finish here and just let you with the questions I have for discussion. If we say that somatic resonance is the emotional basis of empathy, and bioenergetic is working, bioenergetic analysis is using a variable setting, and this is changing the therapeutic attitude into a concrete movement with each other, and can include body contact. So as a result, the implicit path of resonance change. And resonance can arise in many ways, not only through through eye contact and words. I would say neurobiological research is still far from that kind of complexity we would need to explain the process of unconscious interaction during a therapy session. So we have to look for new models and to maybe contribute with another way of research to that. Those things were my thoughts when I was preparing. I hope it was not too much from that part of my person where I was the scientific one, interested in open questions and investigations and researches. But of course, in direct contact, I'm very interested in resonance. And so it was a bit spooky today to sit in front of a black screen and not seeing a person, knowing that there are hundreds of colleagues whom I know or not know. It's a bit strange to have a digital contact on somatic resonance sitting at the screen. Bit spooky, but I hope I could inspire you. Thank you.
Vita, very nicely done. Thank you, thank you, thank you for all wonderful commentary.
Okay.
Just
So
the
it
whole
was
concept of resonance and being able to do that with allowing the body to.
So thank you, and I hope it was not too fast, and that the translator could manage. I hope. Okay. So, are there questions? Oh.
Sorry, Vita.
Yeah, hello.
I can see Rick.
Yeah, and do you see me?
Yes, I see you.
I cannot see Rick, and it's about discussion if there are questions.
Yes, but if Rick, okay. Can I try? Okay.
Yeah.
Nunzia. Sorry.
Rick vanished.
Oh, okay. Can I read one question?
Yes.
Okay, from Nunzia from Italy.
Yeah.
Okay. Should we shield ourselves from patients' emotions?
Shield. I mean, the question is about protection.
Yeah.
Okay. In a very concrete sense, I would say it's all the time allowed during a session to say, I need some distance. I will go a step back in order to be able to breathe better and to feel you better. So I take a step back, or I open the window. I want to move just in order to care for myself and be more resonant again. So this is one type of protection to regulate the distance in the room.
I am so sorry. I had technical difficulties.
Yes, you managed.
I all of a sudden just poof.
Yes. Now you're back. Okay. It was about self-care. The question came up if one can protect oneself from the patient. And I was saying the most concrete and easiest thing is to regulate the distance, and that it is allowed to say, oh, I need to do a step back, I need to take a breath, I need to change my position, it's too near, I'm flooded by your emotional stuff, I need to ground myself and to breathe. So that's the easiest way, and to reveal it to the patient that something is breathtaking or shocking or keeping you off your shoes. So to share the somatic resonance, the countertransference, and not evaluating and not making the patient responsible. I always say, no, don't care about me. I care about myself. And it's not your job. I just share with you that this is breathtaking and getting me off my shoes, what you are telling.
Yes. Oh, I think taking a step back and taking a breath and letting the client know that there's something I need to get more balanced inside of me. Eleanor Greenlee was one of the trainers in Dallas, and some of you knew her before she passed, but she was just remarkable. But she would demonstrate that, and it was so helpful for me to be able to see that in action and then apply it with the clients that I was working with. Yes.
Yes, she was my teacher, and I remember a situation when one guy in our group was revealing that he's sexually attracted by her and that he liked her buttocks and so on. And then she started to have contact with him, and then she said, now I have to go back in order to feel myself and to breathe. It's too near, it's getting too warm. I cannot differentiate anymore between me and you. Thank you very much. So I'm taking a step back. So
Yes.
and that was impressive.
Yes, very
It
nice.
was so nice to see. She was not rejecting him.
Yes.
Yeah.
So I'm pretty sure this is the time that I should be reading the Q&A and offer those questions to you. If that's not correct, the moderator might want to step in and tell me I'm I'm going down the wrong road. But I'm seeing numerous remarks in here. Some of them are in Italian. I'll read the ones that I can read in English. Good evening. Thank you for the interesting lecture. And another one, how to recognize my own projections and fantasies about patient from true resonance, how to practice and or exercise this skill. Does that make sense, Vita?
Yeah, I mean, as soon as I'm aware that I'm going up with my energy and have too much going on in terms of pictures and memories, my own story, my own needs. So it needs to do the grounding, to bend over, of course, and to go back to sensations on the motoric, sensoric level. And I hope that this little piece of exercise I did to tonify the ventral vagus and to unblock the eyes a little bit, that this helps to, we say in bioenergetics, to go out or to get out of projections. If we open the eye block And if this little piece of work doesn't help, then we have to go further and to move the tongue, because the tongue is connected with the tissue, with the neck, with the basic skull, and is also, if the tongue is getting loose, then the eye block is unblocked. So if we have bad fantasies about the patient, the best is to bend over to ground and to put the tongue out and make some noise, some sound which fits with those fantasies.
Yes. Yes, and even in the middle of that session with that client, if we're caught too much in the fantasies, at least that's my experience. Yes.
Yeah.
So we have another question. It is a way to teach self-care to the client too, which I think is beautiful.
Mm-hmm. Yeah.
There's another comment. Thank you. Could you tell us something about the anger aroused by patients with great passivity and how to communicate this to them? And how can I regulate this aggression?
Mm-hmm. So for instance, I like to, if the patient is, how to say, is not in an early disturbed or in an early disturbance mood, I mean, not lost, not confused, not, how to say, I mean, if the patient is stable in that sense that he knows what is going on in the room and is able to have this looking at him or herself, then I can have a commitment that we are not hurting each other. And then I would propose to hit the cube together. One has a racket and the other has a racket, and standing in front of each other, and one is doing one hit and then the other. And the therapist could say, you make me angry, and the patient can say, and you too, you make me angry. And so one would find words for it, but the whole situation is a controlled one, because one hit from one side, the next hit from the other side. It's controlled, not going out of order and not uncontrolled and not blaming the other. It's like a ritual. You can say what you are angry about, and I can say what is bothering me. And so we can maybe exaggerate. We can have a resonance exaggeration or synchronization, same time. We have a lot of contact and safety.
Yes,
One thing, if we want to do this in the session, but if I nearly can keep my anger with the patient and this patient is not able to keep it or to take it in that phase or course of the therapy, I would say the therapist should care for this anger after the session, during the lunch break or in the evening, and hit and kick, but not in front of the patient. If what I said before, if this is an early disturbed person with a lot of anxiety and lack of grounding, lack of consciousness about his or her adult parts, I would say the therapist should care for himself after the session. But if the person is ready to go, then this mutual hitting is pleasurable.
Yes, I think that's beautifully said. And some clients I find get ungrounded when they hit. So I typically, in that situation, have them do a wall sit and twist a towel and use words or sound. Yeah.
Yeah.
Okay, nice. let's see, there's another comment. Resonated also because I had that experience myself, was one of the comments. Thank you. I've resonated with your difficulty of talking at a black screen. How much similar past experiences have an influence on our possibility to resonate? So I'll read that last part again. How much similar past experiences have an influence on our possibility to resonate?
Yeah, I would say to restrict breathing and to restrict pulsation and vibration because of overwhelming anxiety, overwhelming pain may cause a lack of empathy for others. Of course, if we are traumatized, we are not empathetic. If we are rigid, if we are dense and save ourselves by muscular constriction, we are not empathetic. It's only by breathing, by vibrating, by grounding, and opening the ventral vagus, the eyesight, unblock the eye block and the voice, and then we are open again like an instrument. If the violin is tensed, if the strings are over tensed, then there's no vibration, no variation in the sound, nothing. Yeah.
Very nice. Another question. Would you use computerized CT or MRI techniques to look for the areas of neural activation shared by the patient and the therapist at certain moments of the therapy?
I mean, here in Germany, we are not allowed to take the blood of patients or to put some wires on the head to measure things. If we are psychotherapists, we are not allowed. So this is only allowed in laboratorium, in the labors.
Yes.
But I was all the time thinking about what we could do. What we could do is to use a spirometer, for instance. We could ask the patient to use the spirometer before using the breathing stool and later, or to use spirometer and blow up the spirometer before therapy and after 10 sessions and so on. Also we only can use things which are not invasive and not needing too much technical equipment, which is changing the whole relationship, because the patient may have transference on medical treatment, on stays in a hospital as a child, and so on. So I will become a different person if I, as therapist, would apply those things which are medical doctors' stuff. It changes the transference and the relationship. Maybe I'm not going with the question now. I'm just associating what it does to the contact.
Yes.
Mm-hmm.
Maybe the person who asked that question can add some to the Q&A if there's more that they need to understand. But would you explain what you said? Maybe we could use that word again and say what that is.
What?
You were saying instead of a computer,
The spirometer. If you mean spirometer is measuring the breathing volume.
Oh, I see. Okay. I've
You're
used that
blowing
before.
like a balloon.
Yes.
And you can measure the breathing volume of a person.
Ah.
And this is interesting for bioenergetic therapists, of course.
Thank you for that clarification.
Yeah.
Thank you very much for the nice lecture. I like the eyes exercise very much. Why did you choose specifically that one?
Because I wanted to open or to give you a feeling how it is to open in a very simple and short exercise the ventral vagus and unblock the eye block, which is then opening the perspective, opening the breathing, opening the hearing, and the capacity to hear other human voices, and to be concentrated on human contact. So it was because I imagined how it is to sit at the screen and not having real contact with Rick and with me and the others, and how it feels with this digital contact and what it does with our eyes and our body, how it infects the breathing and the feeling, the sensation. So I was curious to offer a little piece of work on the ventral vagus and the eye block. We could not work with the feet at the screen. I mean, we maybe.
Okay. Another question, is it possible to deal with depersonalization and derealization disorder with this type of work?
I would say yes. If one holds on to sensoric, motoric level in while having sharing exchange. So I remember on this pyramid of the self, this picture or this graphic we got from Daniel Sturm, and the basis is somato or affect motoric sensoric without interpretation. So if people are in derealization or depersonalization, they need very concrete sensoric experience and concrete description or exchange, verbal exchange. So it's only about those qualities like it's warm or cold, it's hard or soft, it's light or heavy, it's dense or not dense, it's loud or not. So to contact the person with those concrete resonance sharings, like, oh, it feels heavy now, it feels light now, it's warm, it's cold, and maybe giving some haptic or tactile experience with objects like the wall, the mat, the cube, or with my body, offering my lower arm, grasp this and feel if this is warm, cold, firm or not, trustful or not. Maybe this is already interpretation. Yeah, but it starts with sensomotoric. Yeah, no interpretation.
Yes, very nice. Another question, which course about the use of the voice in therapy would you recommend?
Which course?
Yes, she's asking about a course, and I think you learned that just firsthand through Ben Shapiro.
Yeah. I mean, there's nothing against entering a choir or shouting and singing in the car when you are alone. And there are a lot of opportunities in yoga now, like laughter yoga and something. So I myself, when I was meeting first time Bob Lewis in '92, and he was saying, "Oh, what's about your voice?" Then I was later on in my hometown asking a singing teacher. I was phoning him saying, "I cannot sing, but I want to work on my voice." And I went there for 1 year, and he was from the theater, and American guy from Oregon. So he was working with my voice, with my grounding, standing, raising the voice, breathing, and everything. So I didn't have to sing because I was shy at that time. But I went straight ahead to a person who I said, I want to work with my voice, additionally to bioenergetic therapy.
All right. Please, may I ask, if it is possible, to explain what you said about the communication that comes from the patient's right part of the brain to the left part of the therapist, or vice versa.
Oh, maybe that's a misunderstanding. I was quoting Alan Shore, and he was stating that the therapist's right brain hemisphere and the patient's right hemisphere are communicating in a therapeutic process. Beside the verbal stuff and the conscious left brain or left hemisphere stuff. So the right hemisphere of the therapist and the patient, they are communicating unconsciously.
And this one, I think, is just a comment. Please, I'd better understand your position concerning Porges' theory in your vision. Maybe this person is asking, is there a better way to explain your position concerning Porges' theory?
I mean, Porges is everywhere. Everybody is adapting his concepts. And I was just trying to combine our grandfather or grandfather Wilhelm Reich and what he was doing to unblock the ocular segment, and then applying the knowledge we are now having from neurobiology, like Porges is explicitly writing that in a traumatized situation, the eyelid is dropped, the sound of the voice has no variety, no variability. The mimics are frozen. Everything is influenced by the fight, flight, or by the shock, by the dorsal vagus, and tonifying the ventral vagus, which is then for social exchange and friendliness and being open for the social world again. This is done by some very effective, and they seem to be little, those exercises, but the more often you're doing it, you will see it's very effective. It seems to be simple, but if you are combining it with the tongue, with the work on the tongue, and with the iliopsoas work, then one gets out of the restricted vision, out of the tunnel look, and out of the fight-flight system. And this is, you can do this as a 80 or 90 years old person sitting on a chair. I mean, or if you have not much space or time to do it, so you can do it everywhere. So it's easy. It's not that I'm simplifying things, but in a way I try to make it simple, to apply complicated things with simplicity.
Nice. So there's another question. Group training with techniques for working on somatic resonance can be done online?
No. No, I'm the wrong person for this question, because I'm not a friend of online. I mean, I like to give supervision online. That's easy, and that's effective, I feel. If people are sending pictures of patients or videos, it's easygoing. And if I know this person from a real situation, but training online, exercising in my living room here and showing people what I'm exercising here has not the same effect in terms of somatic resonance than being in the same room and having the atmosphere and the synergy of a group and all these sensations and feelings. So I'm not, maybe I'm from the last century, but I'm not friend of online somatic resonance trainings.
All right.
So
another question. If the patient refers to have panic attacks only in medical treatments, what would you suggest to do? Or to let him do in the room and during the episodes?
if people are having panic attacks, I recommend 200 kicks on the mattress, because this is then enhancing belly breathing instead of holding the diaphragm up. That's one way. The other way, I recommend to do the yoga exercise cow cat, and doing the cow with inhalation, like having fear.
Yes.
So looking at the ceiling and like this, and then doing the cat and exhale and like this. And practice this, because many people who are having panic attacks and anxiety disorders, they have shallow breathing. Second, they have a blocked diaphragm. And so they need to learn how to move the diaphragm, how this can move with exhaling and inhaling. And so the cow-cat combined with sounding is appropriate to practice this at home. So I give homework to people with anxiety disorders. And I say they should go for a merry-go-round or this roller coaster. If this is in their city, they should take the roller coaster and scream.
Oh, yes.
So it's,
Yes.
I mean, I don't, maybe I'm too, how to say, I'm not superficial with it, of course.
Right, right.
Sorry, Rick.
Yes.
We have time only for the last question.
Yeah.
All right. Now, I have finished all the questions in the Q&A that I can find that are written in English. So let me look on the chat and see if I can find a question there that would be a good one to
Okay.
ask.
One moment.
Maybe there's one that you can translate into English, Marco, that you feel like would be a good question to wrap up here?
Oh, okay. One second. I okay. Ilaria asked she would like to better understand how the polyvagal theory is expressed in the therapy sessions in your job, obviously.
Mhm. Um, I just can repeat myself during my talk, and later on I try to explain that if the dorsal vagus, or the shock reaction, or the fight-flight system is all the time active, we have to look for some body exercises and for, of course, a safe relationship with the therapist, a trustworthy relationship. But they are very effective exercises to tonify the ventral vagus, and this has to be done by practicing exercises for the basic skull, for the eye ring musculature, and for the tongue, and for the iliopsoas, to get out of the fight-flight system and of the shock state. But if it's a relational trauma, of course, only relation is healing, relationship.
Yes. Very, very nice.
Thank you, Rick.
Oh my gosh, thank you, Vita. I am
So,
so pleased with what I've experienced here, and I'm sure that's true for many people. I scanned through a lot of the commentary on the chat box and noticed that many people were saying, great lecture, I got so much from this. So at the time, there were over 600 people listening to what you have to offer. So obviously, many people are walking away with some golden nuggets, things that they
okay.
can use with their clients.
Oh, I'm happy about hearing this, because I didn't follow the chats. I mean, I could not read what people were writing. I hope that they got something or got inspired to read further, to work further. And I'm happy that we could cooperate that way with the organizer, Marco.
Yes.
Yes.
Yes, thank you very much.
Thank you, Vita, and thank you, Rick.
That you got not panicked when we started lately with technical stuff. And thank you, Rick.
Indeed, indeed. So you mentioned earlier, Vita, just for people's edification, that you have some articles that are on the IIBA website, I believe you said.
Yes, they are published in the IIBA journal, but people could go to my website. It's Vita Heinrich-Clauer .de. And there are papers you can download. The one on self-care, working with the voice, and what else? Maybe the one on negativity, I don't know. Or they can write me an email, because on my website there's a contact possibility to write, and I can send a paper. But in the IIBA journal, there are some. The voice, the resonant paper, and self-care, and working with negativity.
So people can follow up from this webinar and be able to illuminate and get even a greater sense of these concepts and the way that you approach these ideas. Well, thank you, thank you, thank you. And
Yeah.
Sorry. Patrizia Moselli from SIAB, the School of Bioenergetic Analysis is, in Italy, said that Vita will be in Ischia on April.
Yes, it's
the
a
SIAB conference.
beginning of April. There is a conference on Ischia, and oh yes, good that Patricia is reminding on that. I will be there and give a talk and a workshop, and it's all about the implicit resonance, and Galese is holding or giving a talk, and some others. So it's the 3rd or 4th of April, this first weekend in Italy, on Ischia.
Good. See you on Italy, in Ischia, in Italy. Okay.
Yes, yes, yes.
And
thank you.
Thank you, Vita. And the last information, the next webinar will be with Angela Klopstek. It's correct. And will be on February 22nd at the same time. And see you on February. Okay.
Okay, thank you. Bye-bye.
Thank you, Vita. Thank you, Rick.
yes,
Thank
indeed.
you, Rick.
Very
Yes.
nice.
Yes, you can. See you.
Bye-bye.
Bye-bye. I will write an email if I have come down. Okay.
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 Bye-bye.
Bye.